Start now?
Yeah, we can.
Okay. Yeah, or you can start the countdown. Okay.
We are live now, sir.
Okay. Good evening to all of you. I'm Dr. Ajoy Shetty on behalf of the Pediatric Spine Academy. I'll invite you all for this interesting seminar. The Pediatric Spine Academy was the brainchild of Dr. Abhay Nene, and along with him, 8 of us, we started the Pediatric Spine Academy with the aim of disseminating the knowledge of pediatric spinal problems across India especially, and throughout the southern part of Asia. We are conducting a series of seminar, and this is one such. The topic of today is the role of vertebral body tethering in current practice. We all know that adolescent idiopathic scoliosis is one of the common pediatric deformities, and fusion has been the gold standard. There have been a change in trend in pediatric deformities in the lower limb with the use of growth modulation. And similarly, in the last 5 to 10 years, the vertebral body tethering is becoming popular in the management of adolescent idiopathic scoliosis. We have two eminent speakers, Dr. Sajan Hegde, the past president of the ASSI, and one of the pioneering surgeons in India, and the first and the only one so far to take up vertebral body tethering. He'll be delivering his talk first as to why did he choose to take up non-fusion in adolescent idiopathic scoliosis. The second speaker is Professor Ahmet Alanay from Turkey. He is also one of the significant researcher and a pioneer in the management of adolescent idiopathic scoliosis, especially with vertebral body tethering. I request Dr. Sajan to deliver his talk. Over to you, Dr. Sajan.
So, can you see my
Yes.
first slide? Excellent. Yeah. So basically, I must say, I'm really excited to join today's discussion on what I would call a relatively new concept and philosophy in treating spinal deformity in children. I must say I appreciate the initiative taken by Bhavuk, Abhay, Ajoy, Appaji, and others. I see that Ahmet from Turkey is going to follow me, and as all of you may be aware, the Turkish group of surgeons have been one of the early adopters of this technique. As Joy said, I'm the only guy in this part of the world, but that's what I have done for the last 30 years, I guess. I have to take the lead, kind of lead into a dangerous area and check out before others can follow, I guess. Right. So let me start my story. It starts some 3 decades back. You can see this picture here. Can I have that? This one. Yeah. So I'm going to use this laser pointer. Yeah. So you see this guy. This is Daniel Chopin. And I was at the Institute Calo, as you may. I was perhaps the first spine fellow from this part of the world to go there. I have told this story many, many times. And that was the mecca for spine surgeons to learn about segmental fixation, the CD revolution, the derotation, the fixation, etc. So when I came back, actually much before I came back, in the 80s, the spine deformity landscape mainly had orthopedic surgeons who also had interest in spinal surgery. And while one group corrected spinal deformity, as you can see, using the Harrington rod and keeping patients in bed for 3 to 6 months or mobilizing with a plaster jacket, the other group used the Lukey rods And this was, in the West, primarily used for neuromuscular scoliosis. And the Indian surgeons that were using these saw advantages for this low-end technology, like a low-cost way to correct spinal deformity. And so they felt that in a third, we are talking about India in the early 90s, I guess, in a third world country like India, that was an ideal way to go. So when I came in the early 90s and suggested we should not look just at the frontal deformity, but also at the sagittal alignment that, as you see here in this child with the thoracic scoliosis and hyperkyphosis, and have a look at ways to address with segmental instrumentation, not just the frontal correction, but also getting a normal sagittal profile. And because of the segmental fixation, allowing the patient to be up and about and leave the hospital in a few days without any brace or plaster. So when I suggested in those early days these concepts about the future, the Harrington rod specialists, I will call them, and surgeons preferring Luke instrumentation pushed back with vigor. And as I said, they said there was no place in India for what they called as fancy instrumentation and techniques. Of course, fast forward to more recent times, and for over 30 years, most of us, like most deformity surgeons, I have been using the posterior techniques, and we use posterior pedicular fixation to address spinal deformity, as you see here. But we are doing what I call as iatrogenic ankylosis. And always at the back of my mind, there was this nagging doubt if this was the best way to go to do for a growing child with aspirations in sports and dancing and other activities. Of course, as all of you know, my guru and mentor was Professor Jürgen Harms, and that had a huge influence on my early thinking and way I went correcting spinal deformity. And he taught me anterior spinal deformity surgery. So where you see here a huge Lenke 3 minus type curve with kind of a little lordotic thoracic spine. You see the clinical pictures. The child already has a rib hump. So we look at alternative ways to correct. And this was the way, like a small group of surgeons, mostly European surgeons. And I used to do it here, that we saw advantages, that we could reduce blood loss, we could get better derotational correction in some deformities, we could save levels, and we looked at talking about the advantages of this type of correction, as you see here. And it's the same child growing up to a young woman, and she has a nice frontal and sagittal alignment, and you can see a good clinical correction. So you see also in this patient with severely dysfunctional, dysplastic pedicles, as you can see here in this acute, almost angular deformity. And putting pedicle screws would have been very difficult. The advantages of anti-instrumentation are obvious here, a good correction, and you can see a good clinical restoration. She has a beautiful alignment. But as you know, a lot of key opinion leaders of the day in the last decade of the last century and early part of this century promoted, because in North America, there was a tendency for most spine surgeons, and it is unfortunately also happened here, that surgeons are primarily familiar with posterior surgery, and they do not have good exposure to anterior surgery. And like in North America, you would legally need an anterior exposure surgeon to help you, which complicated things. So people tended to focus more on posterior surgery. Now, as far as, like you see in this child, young boy, with a significant progression from 2020 to 2023, very severe curve. As you can see, that the boy has a severe thoracic deformity, also an upper thoracic curve. Now, in a case like this, there is no debate that the posterior pedicular instrumentation is the best way, because you have to correct from almost T1 to T12 or L1. And you can see the child has an excellent correction, and he is able to get back to normal activity. He loves playing basketball, and he could do that. But I'm revisiting curves like this, a typical Lenke 5 type curve, a primary lumbar curve. And I did this, and I was very happy in those days. But we are fusing the most of the mobile part of the lumbar spine in a young child, and whether there are better ways to address this. So I come back to these two legends who have greatly influenced me. You see Professor Harms here, and then you see Randy Betts, and both of them have played a very important role in the way I have been thinking about spinal deformity. So here, almost 8 years back, we started looking at other ways to treat spinal deformity. And this was a 10-year-old child, Risser 0, premenarchal, classical right-sided thoracic deformity. And this was one of the earliest cases. As you can see, we have used the non-fusion technique. And let me just explain that I do not like the word tether, because a tether has a little, it doesn't convey entirely about the technique, new technique. We prefer to call it non-fusion, because we use it as a technique of correction. And that element of inertia which one sees in a tether is taken away, and we prefer to call it non-fusion. So that's a little explanation about how we look at it. We do not call it tethering anymore. We call it non-fusion. The technique, of course, remains more or less the same. So here you see that we have instrumented the main part of the deformity. A good sagittal alignment is also given here. And here you see the clinical pictures. But you see there is a little bit of undercorrection, which is intentional. And at 4 years, you can see her spine has spontaneously corrected, and she has an excellent frontal correction, almost no scoliosis. And you can see the clinical picture. It looks beautiful, and no scar on the back. But you know that most of the early leading lights in this area did come out with reservations. And this landmark article, which came many, many years back, which had a considerable impact on the thinking and the concept of non-fusion. This paper presented less than acceptable outcomes. But those who are interested in tethering or non-fusion should revisit this paper, because I personally feel that if you are using it, a technique for the first time, use it only for the most ideal cases, which I think was not done in this study. Of course, leading journals quickly jump into it, and you can see a little bit of bias here, a little bit of resistance to accept the new technique. And you have this deputy editor for JBJS saying that the tethering juice is in its current form is not worth the squeeze. I guess they mean that this technique doesn't have a future. So, but I will try to show how this has evolved with us, and definitely we feel this this has a fair amount of juice. So today, in a 14-year-old girl, like you see here, Lenke 5, it is very unlikely that I want to strip her lumbosacral paraspinal muscles to put a posterior instrumentation, say from T5, L5 to T10 or something. But this minimal invasive way to do this correction seems the way to go. And at 2 years, you can see she still maintains a good correction, an excellent sagittal profile. You see it just gets better over time. And the clinical pictures show that the girl is grown up, and at 2 years, she has a good restoration. So this 12-year-old child, Risa 3, Lenke 5, as you can see here, she has already in year 1, there is a little breakage. If you compare it here, there is a possibility of breakage. And at 2 years, there is possibility that she has broken at one more level. And she has added a few degrees to what was a fairly excellent initial correction. She has added a few degrees, but she still maintains a good correction. Her sagittal profile is also good, as you can see here, despite the breakages. And her clinical follow-up at 2 years shows she is well balanced and with good symmetry. So now we have a very rigid and meticulous protocol where the scrub tech, the X-ray technician, the surgical team, the anesthesia team, all work in unison, and they know exactly how, because these surgeries have to be done in a very predictable manner to have the best outcomes. And a double curve like this, if addressed with the standard technique, you would fix maybe from 5 to T3 or T4, and with at least three units of blood required at the time of surgery. So this child has a double curve, 71 degrees, 66 degrees. And this is something we have been trying to stress, the importance of the traction film, which gives us a good idea. This also allows us to sit with the patient's parents and explain to them the kind of correction we expect when we do the non-fusion correction. And you can see here, post-operatively, the boy has a good correction. This boy came from Philippines. They had done their homework. They were not keen on standard techniques, which they could have gotten done in Philippines or gone to Australia for that. They did not want that. They came here. And you can see the boy, the same day, after a bilateral thoracotomy, 4 hours after surgery, he's up and about, doing the breathing exercises. We like our patients up and about the same day. And 2 nights in the hospital, and they leave the hospital. You see an excellent sagittal profile here with the double curve corrected. So what's in, what's out? For Lenke 4, a triple curve, where the upper, that is the proximal thoracic, is showing good correction in the traction film, we prefer to correct the two major curves, and we get good correction. And like you see here, the child the same day mobilized and has an excellent correction, good sagittal profile. And at 1 year, she has a good, she's maintaining well, and she is very happy. The key thing is the children are able to return back to doing everything that they love doing. In this case, the child loves Bharatnatyam, and she is happy to do that. So whether we would do it in the classical Lenke-1, because there is really no advantage in the Lenke-1, but some patients do come looking for us. But the only thing that you have to say is if they have a structural deformation of the rib cage, you do not get a dramatic correction of the rib cage if you're doing non-fusion. This was a 20-year-old girl. She was very keen that she did not want any standard posterior correction, and she was very happy after this anterior non-fusion correction, and at 1 year, she's got a good sagittal profile. Before I finish, I just want to show you that we can push the limits with the non-fusion. So here you have a child with an hemivertebra at the dorsal lumbar junction, but he has a deformity which is almost like a double curve. And if you just do a localized vertebrae, excise the hemivertebra and then fix and not address these deformities, the child is still left with the deformity and it has no benefit to the patient. On the other hand, if you look at it as a deformity and put extensive instrumentation in a 12-year-old boy, RISA 0, you're looking at significant restriction of the vertebral growth. So we do a traction film, you see good straightening of the spine. This is critical for us to decide whether the child will have a good result. So we decide to do an excision of the hemivertebra. You see the hemivertebra here in the 3D recon, and doing a correction of the lumbar deformity as well as the thoracic deformity with non-fusion. And at 2 years, you can see he is still holding well. He has good correction. He has shown some growth and some spontaneous correction and maintenance of a good sagittal profile. You see it has improved over time. Here are his clinical pictures, and at 2 years, he is very well balanced. Now, some of you would say, hey, maybe this was not the right thing. You should just address the hemivertebra. I think that would not have been an ideal way to correct in this young boy, and he has had a good result. Now we are coming to another child. They came all the way from Kashmir to see us. They had already been advised standard surgery. As you can see, the child has some thoracic rib hump, some counter curve in the lumbar hump as well. And this is where things can get a little sticky when you decide what you should do. It's a very significant deformity, and almost 80 degrees or 90 degrees. I think we have this measured here. So the lumbar curve was 75 degrees. The thoracic curve was 106 degrees. So what is the option? So the patient's family parents they were not very keen on complete standard posterior correction. So we did lumbar spine, we did the non-fusion, and for the thoracic spine, I think our Turkish specialists will talk a lot about this hybrid. They were one of the first groups to accept this. And you can see that she has an excellent correction. her thoracic spine, the deformity was 106. It's now just 15 or 17 degrees. And her lumbar curve has come down to 16 degrees. And you can see that she has a good sagittal profile as well. Here you see her clinical pictures. The thoracic hump has also been reduced considerably. And at 1.5 months, she looks good. And we hope she will maintain well. So this is our current pictures. So to just quickly run through the data, most of the Lenke 5s and the Lenke 1s are the main ones that we have done this. We use the non-fusion, and the blood loss is, as you can see, absolutely negligible. We do not use, in the last almost 100 cases, we have not put any chest tubes. We don't put, even if we do a double thoracotomy. No patient gets a Foley catheter because they are up and about few hours after the surgery. They show a good correction, which is as much as the standard posterior techniques. And they have been maintaining the follow-up corrections as well. There has not been any significant loss. Now coming to, people have called this a dangerous technique. People have talked about thoracic duct injury, atelectasis, ureter injuries, so many things. But it is the way you do it, and it is also the familiarity with anterior surgery that helps you to, when you do use this technique. In our study, we haven't had any intraoperative or postoperative complications, though a couple of our patients had to be returned back to the recovery area. I think one of them required intubation because they had mucus plugs which were blocking the lungs. So this is our experience. I think non-fusion is no more an orange without the squeeze. I think in good hands and in very good people who are familiar with anterior surgery, this is the option we can offer to our patients with young patients with spinal deformity. Thank you.
Thank you, Sajan. I think Dr. Ahmed is held up in emergency surgery. We will have a lot of time for discussion.
He sent a message, he's joining in 5 minutes.
Okay, good. Till that time, Sajan, we will have certain clarifications on the technique per se. I know that you use traction during surgery when you are doing a usual adolescent idiopathic fusion surgery. I would like to know a few things. Number one, do you use traction in this surgery?
No, we cannot use.
Yes.
That's a very good question, Joy, but we cannot use. I have thought about it, whether we can put, but the way we position our patients, there's no way we can put the patients on traction.
Yeah, because it's a lateral position.
Yes.
Yeah. And secondly, usually the fixation is from end to end of the curve, or can you shorten it, or is it necessary to be longer?
So, of course, there was no scope to talk about it. The selective fusions in curves is something that we are looking at, even in lumbar, in curves where, like a Lenke 1, where you would normally go to L2 if you are doing a posterior instrumentation. We sometimes stop at D12 or sometimes at L1. So yes, we can save levels.
Okay. You have been emphasizing significantly on traction films.
Yes.
Therefore,
I think this is something that Ajoy, even our Western colleagues have not been able to understand the correlation of the flexibility that we can demonstrate on the traction film, how important it is. it was something, as you remember, you have seen us show this even for our posterior cases. We have been doing it right from, I've been doing it for donkey's years. But it is of critical importance when you're doing non-fusion.
What exactly is the role? Because I saw in most of your cases with the traction films, it demonstrates the flexibility.
Yes. So my team has Dr. Sharan, who was one of our earliest spine fellows. He worked on this. I think there was more than 50%. More than 50% correction is an absolute must. So if you don't have that flexibility, you're better off telling the patient that posterior surgery is the way to go.
Okay. Very good. Now, currently, what is your indication? Do you look at the skeletal maturity, Ahmet joint?
Yeah. So no, the skeletal, we look at it. We have done it even in older patients. We have recently had a young lady who was a doctor, but she did not want non-fusion. But we look for flexibility. The critical thing is flexibility. Of course, I would like Ahmet to discuss his philosophy. I know in Turkey, one of the senior guys used to use traction under anesthesia for our standard posterior corrections. I don't know what they go by, but we use the flexibility that we see on the awake traction films.
Thank you, Sajan. We will have the further discussion later on. Now, Dr. Ahmet, thank you for joining us in spite of your busy schedule. We have already introduced you. We would like you to share your presentation and start off with the talk.
Thank you so much. And I'm so sorry for being late. I think that was the time difference, maybe, that really confused me. But now I've just finished my operation and happy that I was able to join. And I will share my screen. Just a minute. Okay. Okay. Can you see my screen?
Yes.
Okay, good. Okay. Yeah. Thank you very much, first of all, for the kind invitation. I think Sajan has talked before me, right?
Yes. Yes. Completely.
Okay. So some of the, unfortunately, some of the things may be, the same thing. So I'm sure here are my disclosures. I'm sure as he has mentioned about VBT, maybe I can pass these parts very early. But fusion has always been, although the gold standard, still the gold standard, and majority of my practice is fusion, not VBT. But I still believe that, I think everybody believes that fusion is not a physiological treatment method at the end of the day. And we have to find some solutions, and VBT has came to our practices as a reliable solution for that. As Sajan has mentioned, first, I have also started my indications in terms of using the Hütter-Waldman law, applying compression on the convex side, and which would be creating some traction on the concave side and decelerating the growth on the convex side and accelerating the growth on the concave side was the main idea. And so I started with the current FDA HD indications for both thoracic and lumbar spine. But I think even the US guys were not doing the lumbar spine in the beginning. Once we had our confidence in the thoracic spine, we started using this technique for the lumbar spine as well. And these are, of course, curves over 40 degrees, failed bracing. Still, we don't have the FDA indications here, but that's a prerequisite for me. So field bracing is the main treatment method for me for those curves less than 40 degrees and growing patients. But then once I had some confidence with my practice, then I expanded the indications a little bit more, especially as I realized that lumbar spine is growing differently than the thoracic spine. So especially those patients who are slightly over Sanders 3, Sanders 4, 5 patients were also modulating, having some modulations. So right now, these are my indications. Actually, I do this for every adolescent patient, I would say. I have only very few lumbar spine patients that I've done who were already mature, but young adults, like up to 30 years of age. And as Sajan has mentioned, I think the most important thing is the flexibility, because sometimes, surprisingly, you can see some really very flexible curves, as in this patient, for example. Then I will show you later on this sample. So those patients bending to less than 30 degrees are good candidates, and I don't think that you can find a patient, unless the patient is, syndromic, like Ehlers-Danlos or Marfan syndrome, that will bend, to less than 30 degrees, any curve over 80 degrees. So my upper curve size was 80 and 85 degrees, but these both were gymnasts who were able to, bend to less than 30 degrees. I used the regular flexibility X-rays, although I have been one of the co-authors of the traction X-ray under general anesthesia, and I'm using this in my practice. I rely on the normal bending X-ray, so I don't push with traction X-ray under general anesthesia for my indications. Maybe one point I should mention is, when you look at the flexibility to less than 30-degree criteria, actually, this is not, it should not be measured from end vertebra to end vertebra, as we used to doing, for our fusion cases. I think the flexibility of apex is very important. So I always take into consideration the flexibility of the apex. So I didn't expand my indications to disc releases, which to me, and also I have seen a few patients operated in US with disc releases who ended up with disc degeneration and pseudoarthrosis and tether breakage. And we have seen some attempt to actually fusion, but they were not fused at that time. Rib resection has never been my practice. So this is a typical patient, 82 degrees. But as you can see, it's 70% flexible, bending to less than 24 degrees. This was a professional gymnast that I've done this surgery. And this surgery ended up with a surprisingly very good result, although she pursued with the gymnastics. And at 5 years, as you can see, we had a 22 degrees of residual curve. She reached maturity, and she didn't break the cord. So I prefer to do thoracoscopic surgery. I have an access surgeon who is helping me, and we have done all our procedures over 225 right now by using thoracoscopy. Mini-open thoracotomy may be another way. And I think technically, I'm sure Sajan has mentioned about this, so I will not say on this topic, but we can discuss if you like. So potential advantages of vertebral body tethering, we thought that motion preservation, of course, growth sparing, and then we were expecting less complications as we were doing this with a minimal invasive fashion with no muscle splitting or muscle cutting. And we were expecting rapid recovery, better health-related quality of life as they preserve their motion. And we were thinking that, it would be an alternative to fusion surgery. So if you look at the literature, and I think there are some meta-analysis studies which summarize very well, showing that I think the correction rate is average on around 50%. And we see significant improvements in total SRS-2 and 2 score. The complication rate is simply high in those days, but I think this includes also our learning curve period. And we had a lot of overcorrection in the beginning, but I think overcorrection is now under much control. Tether breakage is something like a natural history. I wouldn't say it's not a complication, because if it becomes early, during the growth, then usually it ends up, with the curve coming back and necessitating a revision surgery or fusion conversion to fusion surgery. But after maturity, if the curve is under control, I don't see the tether breakage makes a big decrease in the profits of VBT or on the advantages of vertebral body tethering. Definitely, there is a reoperation rate of 10 to 20%, especially this reoperation rate increases after 36 months in the longer follow-up. But at the end of the day, we think that VBT is an effective procedure. I will explain why I believe it's an effective procedure despite this high complication rate. And this is Peter Newton's study, especially when done for patients under Sanders 3 and Sanders 2 patients. It definitely provides some growth modulation on the convex side compared to the concave side. But we don't see the same modulation when AP compared to the posterior side. I think that's one of the reasons why we don't, although this is an anterior procedure, we don't get a good correction of kyphosis, restoration of kyphosis after this surgery. So preserving motion is a bit too much under discussion. For thoracic spine, there are some studies showing that a 6 or 7 degree of preservation of motion is possible, but we don't know the clinical significance of this 6 or 7%. But especially for the lumbar spine, it's obviously preserving motion, and all the studies have shown that there was a significant preservation of motion, especially compared to fusion in those patients. So comparison to fusion has been done several times, although I believe that it's not a fair comparison. Definitely fusion provides more correction for those patients, and with similar SRS-22 scores, but definitely less complication rates or reoperation rates with fusion. So one question was about whether it was causing a disc degeneration. And in fact, we have studied this. 2 years results have been published. And now we presented this here in SRS, the 5-year result of the effect of compression by VBT and holding this space by VBT on the disc health. And we have shown that there was no fusion or there was no disc degeneration, which was also very encouraging for us for vertebral body tethering. So why we should not be comparing this? Because I think now there's a general consensus that those patients that we are operating are patients not good candidates for bracing, right? Because they are all over 40 degrees. So the only option is then doing a fusion. So in VBT, actually, we are just kind of internally bracing the patient, decreasing the curve size. And at the end of the day, at the end of the maturity, if we can end up with a curve less than 35 degrees, then we think that although this is a surgery, this is still a success for this because according to the studies, curves over 35 degrees actually, according to natural history studies, are not really causing too much problem or decrease in the quality of life. So if you want really good correction, then of course fusion is the option. But if you want to stay, in a curve magnitude between 0 or slightly overcorrection to 35 degrees, in those patients who are really candidates for fusion, and fusion is the only option, then I think this really makes sense, and then we can accept it as a reliable operation. So that's my approach right now. But of course, we have a lot of challenges right now, and we should be realistic in our expectations. Patient selection still is the mainstay, and we know that flexibility is very important with curve magnitude. Predicting growth potential is now our problem, but we are getting much better. Now we are using Sanders classification, but in my practice, we have started and we have done a study which will be published very soon, looking at the cervical vertebral maturation classification. And we are just blending all of them, the clinical maturity signs and the radiographic maturity signs, including Risser, Sanders, CVM, and all of them. And then finally, we are deciding on, how much correction we should end up. So determining, of course, the amount of correction is still very tricky. And how to prevent complications is the main question. And I think as the main complication is tether breakage, so definitely we need more long-lasting, durable, but still mobile tether integrity. So for how much correction, actually my approach right now is depending on this study that we have done. And we have a little bit, we revisited actually this study, and then now our template is like this. So I think those patients who are TRC closed Sanders 2 are the perfect candidates for VBT operation. And in those patients, we usually try to get 15 to 20 degrees of correction on the table, which goes to 20 to 25 degrees. Because according to our study, and later on this was confirmed by harm study group study, those Sanders 2 patients have an average of 30 to 35 degrees spontaneous correction until the maturity after the surgery. So depending on that, we expect first standing 25 to 30 degrees of correction, and actually magnitude of curve in the standing erect position. Then comes the Sanders 3 patients. Actually, in the original paper, we were thinking that Sanders 3 patients were the best candidates, as we had a lot of overcorrection and tetrabraction in the Sanders 2, but now this has changed. I think Sanders 2 patients having the greatest capability of remodeling, so they are the best candidates. But for Sanders 3 patients, they are still having some modulation, actually around 10 degrees after the surgery until the maturity. So in those patients, I try to achieve as much correction as possible on the table. And for curves, over 40 degrees, whatever you do, actually you can get 60 to 50% or maybe slightly more than 60% of correction on the table. So you always end up with a residual curve of 10 to 15 degrees. So considering that they will correct during the whole maturity stage only 10 to 15 degrees, I think this is enough correction. So these two groups are my favorite patients right now, and I'm still doing, even for the thoracic spine, VBT for those patients. But for Sanders 4, 5, 6, 7, unless the patient is an elite athlete or dancer who really wants to, preserve the motion in the thoracic spine and is ready to do conversion of fusion, once they finish their career, then I have some patients that I can do, selective patients that I can do still thoracic VBT. Other than that, now I'm doing either selective thoracic fusion or I started doing a hybrid surgery. So these are some samples of patients. As you can see, this patient is Sanders 2, 41 degrees. And we have done 34 degrees of correction in the first standing erect study. Actually, this was after our study. I was a little bit curious about whether the Hütter-Volkmann law will work, in this small amount of correction, but it worked very well. And as expected, she was going to, when she was in Sanders 5, going to some overcorrection. But she ended up with tetrabreakage, and when she reached to maturity, she had only 12 degrees of residual curve with a good sagittal plane and also a good clinical outcome. Now, Sanders 3 patients, my expectation is around 10 to 15 degrees of correction. And she was corrected to 21 degrees. And as you can see, she ended up with 11 degrees in 2 years when she reached to maturity, and then she broke the tether. And she ended up at 5 years with a 28 degrees of curve magnitude. And again, good clinical outcome. Sanders 4 patient, this is one of the patients that I did actually after discussing with the parents. 19 degrees. This patient surprisingly didn't have, actually, we were not expecting any modulation, but we were expecting tether breakage. In 5 years, this patient didn't break the tether, and she is also doing fine. For the lumbar spine, I think it's the same. So for the lumbar spine, especially for the Sanders 2 patients, I'm still trying to buy some time by bracing, especially if they are TRC open. But if the curve magnitude is over 60 degrees or around to 60 degrees or approaching to 60 degrees, then I do my VBT for Sanders 2 patients as well. Sanders 3 patients, again, is good candidate, and I try to leave around 20 degrees of curve magnitude in the first erect X-ray. And Sanders 4, 5 patients are still good candidates in those, because I have realized, I don't know what Sajan is thinking, those patients who have lumbar spine has a little bit longer duration of modulation during their maturity. So I try to get as much correction as possible in Sanders 4, 5 and 6, 7 patients. This is a patient, Lanky 5CN, Sanders 6. As you can see, I did as much correction as possible, which was 10 degrees. And then the patient actually had some compensation for the upper curve. but she didn't have any tether breakage even in 5 years with a good outcome. So when bilateral VBT, especially patients with significant growth potential, as I said, send this 2-3 patients for the thoracic spine, because this indication actually is based on the thoracic spine, whether I should do a fusion in the thoracic spine or a VBT in the thoracic spine. So if they are sent us 2-3 patients, flexible curves, Lenke type 3-6, or selected Lenke type 5 patients, and in some selected Lenke 1C patients, then I do bilateral VBT. Or if the patient is again an elite athlete, then who doesn't want a thoracic fusion, then I can do the bilateral VBT as well. So this is a patient Sanders 3, as you can see. So I got this first correction, and by time she had actually great modulation in both places, around 10 degrees in both curves, and then she ended up with a tether fracture after she reached the maturity, and she's doing okay after 5 years. And when hybrid, this is actually indicated, the hybrid ones, those double major curves who are slightly more mature, like Sanders 4 to 7. Because as in my case series, I had a huge number of, or almost around 70 to 80% of tether brackets in the lumbar spine when I do bilateral VBT. That's the reason why I moved to hybrid solution. So for those patients, Lenke type 3-6 patients, especially if cleansed LIV is L4 and below, for fusion, then I slightly encourage more the patients to the hybrid solution. So for selected Lenke 1C and 2C patients, especially for lumbar curves over 40 degrees, now, if I'm too much in doubt about, their waist symmetry, and if they are still not fully mature to do a selective fusion, then I don't hesitate to do a hybrid solution. So, and of course, for those curves who cannot be managed with VBT because of the magnitude of their thoracic curve, as in this patient who had a 90 degree of thoracic curve, which was very rigid, bending only to 57 degrees, and with a 61 degree of lumbar curve, Lenke type 1C. So I did a hybrid operation for this patient, and you can see the 2-year results with a very good clinical and radiographic outcome. Yeah, we have complications, as I mentioned. Tether brackets is the main thing. Adding on is slightly controversial for VBT because this is different than the fusion. There might be some medical complications that we see as case reports. None of them actually happened to me in my practice. Maybe that the reason is, I'm getting a help from an access surgeon, and there might be a need for more additional surgeons. There is no doubt about that. But again, we should always consider that all these complications include our learning curve period. So although there has been, I think, one paper which has shown that there was not too much difference between the 2 years and the 2 years results compared to 2 to 4 years results. I think still we are in learning curve, within 4, 5, 6 years, we are still learning. So I think in my practice, I see now less complications because I'm more careful in my patient selection. So this was a typical example. As you can see, in the 18 months, patient started developing some overcorrection, and he was Sanders 3 at that time. So I had to do releases, and which ended up with a good result in 5 years. So I released these 3 levels. I just cut the tether, and that was the whole thing. And this is a typical both adding on wrong level of selection, because it was in the beginning Lenke type 1 AR, but I didn't notice that. So I stayed from end vertebra to end vertebra. Now this is not my selection of the LIV. I use the posterior instrumentation or fusion selection rules for my LIV because this is not a fusion. This is not an anterior fusion. So I select the first vertebral touch by CSVL, but I didn't do it in this one. Then that was a mistake. First, I was having a at 18 months, some overcorrection, but then some adding on started, and then the patient broke the cord and ended up with some off balance and even worse deformity over 40 degrees than I converted it. But this gave me at least 5 years for this patient to reach to maturity, where she was standards 2 when I've seen her first. So this is a very short summary of my experience that we have published, actually submitted, and it's under publication recently. As you can see, I have a high tether breakage, especially in the bilateral, 80% in the lumbar spine, 40% in the thoracolumbar spine, and almost 30% in the thoracic spine. But if you look at my success criteria, less than 35 degrees, actually it looks like 90%, from 90% to 80% success rate for all curve types. And overall reoperation rate in my practice is 5%. But I have to admit that there are some patients we offered revision or conversion to fusion after maturity, but they didn't want it and they are still under follow-up. So in the bilateral, as I mentioned, 80% tether breakage rate is now around almost 5%. Actually, this reached to 20% right now, but still much better than what I had with the bilateral tether breakage. And of course, when we in the hybrid patients, almost I have 100% of success rate with the criteria of less than 35 degrees. And this is a summary of my practice right now. As you see, my thoracic VBT cases are decreasing. Fusion cases are also decreasing. My hybrid cases are now increasing up to 2022. And this is still the trend. So today, VBT, I think, is helpful for prevention of fusion and preservation of motion, especially in the lumbar spine. Not as effective as fusion if your expectation is in terms of correction and less surgeries. Definitely, there are more additional surgeries, which will decrease hopefully in the future. And still maybe an effective alternative, especially for patients with Sanders 2 and Sanders 3 maturity status, especially in the thoracic spine. And so hybrid surgery in my practice seems to be providing better correction in the lumbar spine with less tether breakage and preserving lumbar motion, and seems to have to be a promoting surgical technique. Thank you. So I was a little bit fast, but
Thank you,
Thank you,
Ahmed.
Doctor.
Yeah, very a comprehensive talk. Unfortunately, you have left us with no questions. You have answered all the controversies in regards to the tether. But however, we need to ask you some questions. What is the role of double tether, especially in the lumbar spine?
yeah. So we haven't analyzed yet, the double versus single, because we changed, in between the instrument that we use. So it's not a fair comparison. But I can tell you, I'm not very happy with my tether breakage rates, despite using of double cord. So double cord definitely is not the ultimate solution, and it is adding more surgical time. And we haven't had any problem, but inserting 2 screws in one vertebra is still a little bit scary, and especially if you have to convert it to fusion, 2 more screws and 6 screws in one vertebra. I didn't have any problem yet, but I think that is not the ultimate solution, but that is still my preference, especially for the lumbar spine. But we definitely need stronger single tethers.
Yes, Sajan.
Ahmed, great talk, wonderful stuff. What are your ideas on doing this one-level fusions? Bert Robish has been doing a lot of that, and he claims it may be the answer to less incidence in tether breakage. What is your thinking along that? 1. And 2, I have not done any disc releases. I somehow don't believe in disc releases. I know Olaveri in New York has stopped doing disc releases. What is your thinking on that?
Yeah. Sajan, first of all, that apical fusion Per is doing, I'm really looking forward to see his results.
Yes.
I didn't start doing that. It may only be indicated for those lumbar curves where the apex is not bending to less than 30 degrees and where the apex is wedged, okay? But those patients are not good candidates for me for VBT because in my practice, in my hands, VBT is non-fusion minimal invasive solution, okay? So if you do disc releases and then if you do fusion, apical fusion, then what is the point doing a VBT? That's one point. I am very happy with my results with the hybrid solution. So that definitely decreases the tether breakage rate in the lumbar spine. And for the apical fusion, actually one of my cases from Australia was revised by Mike Selby with the pertropish method. And I have seen that the patient broke the tether in 2 years, not at the fused segments, but at the L3 and L4 segments. And in fact, if you look at our lumbar series, the majority of them break their tethers at L3, 4, and L2, 3, and L3, 4. Sure. So what is the point to do a fusion? I mean, that's my honest source right now, and I tell this to Per as well. But I am really looking forward to his results. This releases is, I mean, it's nonsense.
I agree. Yeah.
Appaji?
Yeah, Professor Ahmet, Appaji here. I've been in
Hi,
touch with
Appaji.
you. Yeah,
Yeah,
so
sure.
I work with Sajan here, and we've been doing these non-fusions here. He started off. I was not convinced early, but now I'm more and more inclined to tell non-fusion for patients. So my question is, why is it not that people are accepting it as a treatment choice? I mean, amongst the surgeons, I'm not asking about the patients because patients are now coming and asking for non-fusion. Why are they not convinced? First question. Second question is, in a situation where you have to tell the patient that there is non-fusion available, but the patient, most of the time, patient has already had an opinion that fusion is better. So how do you tell these patients? I mean, there is an undercorrection. So what do you tell these patients? How do you accept that undercorrection?
Yeah. So actually, there was a huge trend coming from the patients and too much push by the patients, to have a VBT surgery, maybe 5-6 years ago. Now this is decreasing, definitely. So we don't have that many patients. I think this is because of the bad publicity about VBT and also, those published results. Why people are hesitant to go? There's always early jumpers to this sort of techniques, and there's always a cultural barrier, when you do something new. Okay, so and also our results, unfortunately, right now the evidence is not strong enough to convince those surgeons to do VBT surgery. The other thing, our generation is very much used to, doing anterior surgery, but as posterior surgery, VCRs and everything has been more trendy. Now people are also hesitant to do anterior surgery. I think if this would be a posterior VBT, believe me, there would be more people, trying this. I think that's also one of the reasons. I have always been an early jumper to several technologies, early adapter in my region. And I was also an early quitter I quitted early for many technologies that I have seen that it doesn't work. But surprisingly here, there are patients who really encourage, very successful results, which really encouraged me to do this surgery. But sometimes, I see some big failures that I regret that I did my VBT surgery. So even I myself, although I am one of the pioneers, I am not a promoter of this surgery. I have to discuss with the patients, at least an hour about the advantages and disadvantages of the surgeries. Now, actually, I regret sometimes, I started doing this because I have to talk with the patients longer and longer and longer. And you cannot say that, you have to have this surgery, you have to do this surgery. And there has been times that I tried to, convince the patient that VBT is not a good surgery. So for surgeons like us, very busy surgeons, let's say, I wouldn't say waste of time, but you have to, discuss all the points. And one of the other disappointing thing is, when you see them 3 years after the tether breakage, you realize that they forgot about everything. And then when you say, now this tether has broken, and then they look at your face strangely, and then they question you, why does the tether break, doctor? Why is that? So then you feel, really, I don't know how Sajan is feeling, but especially, I'm working in a private hospital setup, so I don't like, their faces. So I think, but I still see that, there is definitely a room for this surgery, especially with the right indications. I will be insisting on, doing this surgery. I didn't quit yet. And also the engineers are now working. Definitely, this is, I wouldn't say a revolutionary step. Maybe this is an evolution, but I think we are going to do non-fusion solution, starting with tether. So my suggestion for the young people, yeah, I mean, I think for the selected cases, you can do this and you can be a jumper.
Thank you, Dr. Ahmet. Second,
very well put, Ahmet. I think you brought it out beautifully, where non-fusion stands. And I think we have had questions both from our colleagues as well as our patients. And we have now getting there to that sweet spot where we know this is very good for certain types of patients, and this is not good for a certain type of patients.
Exactly. We have these, I think, the borders now. I think we are more solid.
Correct.
In our,
correct.
In our brains. Yeah.
Thank you, Dr. Ahmet. Sir, Ajoy sir, you have any other question?
Yeah, Pankaj.
Hi, good evening, Professor Ahmet. It was an excellent talk. I have one question for you. I'm Dr. Pankaj Kandwal. I'm from northern part of India. And yeah, so I just have a question. What would be your ideal treatment for a tweener?
For tweener, right? Is that true?
So would you like to fuse? Yeah. Would you like to weigh?
Yes.
Or would you just
again? Yeah, that actually, I think VBT, tweener is a very wide range. So VBT is actually the exact solution for the tweeners that, we were looking for many years. So if the tweener is age 10, Sanders 2 and 3, I would definitely go with VBT. But if the tweener, although age 12 or 13, now, I mean, chronological age really is not the thing which is, helping us. So I would go for a selective fusion, especially for Sanders 3 and 4. I don't think that we will lose anything, by doing a selective fusion, because I don't think that they are really growing a lot. So maybe we should leave this phrase of tweener, and we should be relying on radiographic and also the clinical maturity signs. So again, Sanders 2, 3 patients, I would definitely go with VBT. If Sanders 4 or 5, I don't think tweener will be a 6, but 4 or 5, I think I would go selective fusion for the thoracic spine. For lumbar spine, always with VBT, especially if I have to stop at L4. I'm not, I'm telling to patients, there are patients still concerning about tether breakage. Even I do a hybrid surgery and they want to get fused. But doing a fusion at L4, something I really very much dislike. And I try to convince those patients to have a VBT for the lumbar spine or a hybrid if it's a double major curve.
I have one more question here. So you've decided on fusionless surgeries. So would you prefer a growing rod or VBT, knowing the truncal height?
Yeah, so for tweener, you mean for the tweener?
Yeah.
Well, again, I mean, it's not whether, I mean, that's their chronological age. So now, those patients I was doing, I tried Majak rods, but, after some time it doesn't push. So you can get only 1 year or 2 year, delay in surgery. I don't think that it really works, doing it, a growing rod. I came to the conclusion before VBT that those tweeners should be fused at that age, because when you do a fusion of 10 to 11 levels or 7, 8 levels, I don't think that they have laws of height at those segments. Okay, but now with VBT, if I can do, then I do a VBT. Otherwise, I go with fusion, and I don't want to go with the drawing rod techniques, whatever it is.
Thanks.
Thank you. Before you end, one last question to both of you. Do you think posterior tether is a feasibility?
But Ahmed, you have, I hear, I see some uploads on LinkedIn about posterior. I think the surgeon from Portugal, I don't know if you're, he uses it. Do you think it's the way to go? Do you think there is some role for it?
Well, there are some anecdotal cases, especially they do more for the length type 5s.
Yes.
But yeah, and also there was one guy in Turkey who showed his case to me. The problem is, they are already, because of deformity, hyperlordotic in the thoracolumbar junction. And when you compress, then they become more hyperlordotic.
Correct.
And then there is a great failure rate. So yeah, the Portuguese guy shows some anecdotal cases which seems to be working well, but I don't think that maybe the indications are very limited, and I don't think that they know yet who are the best candidates for that.
Correct.
There is also another use for Scheuermann kyphosis that I have seen. Now, two of these cases are in my list for revision. Also for Scheuermann kyphosis, I don't think that it works, but there are some anecdotal cases, and I'm not sure they were real Scheuermann cases or some posterior problems. So I think we should be working on that. As I said, if we do this posteriorly, there will be more interest. Hopefully, if we can get some better results, but I don't find it yet safe and efficient to do posterior tethering.
Correct. Absolutely. Agree with you fully.
Okay. Then I think thank you both for an excellent session. It was very comprehensive and updated as to the state of tether today, our growth modulation today. Thank you.
Thank you so much for the kind invitation, and looking forward to see you soon.
Thank you again.
Okay. Thank you. Bye-bye.
Bye.
Bye-bye.
So before we end, we'll just thank you all the faculty and thank you all the members of the Pediatric Spine Academy for being here. So before we end, we'll just like to update you on our next session, which is on the 12th of December, and it will be on lanky type 5 curves. So hope to see you all soon and all the audience soon. Thank you so much once again to everyone for being here. Thank you.
Thank you, Hriday.
Bye, Appaji, Sajan, Ajoy. Bye-bye.
Thank you all. Bye-bye.
Indigo